So, at this point, in a few minutes, I'll have all the case study grades in. That will leave you with how many points left. Everyone's last lab quiz has been put in. Everyone's lowest lab quiz grade has already been dropped and adjusted. All that's left, 125-point final exam, 50-point lab exam number 4, and a 5-point PAL quiz, 175 more points. Okay, that's what's left. Plus, there'll be the extra credit quiz that's due Friday or Saturday. Plus, there'll be the adjustment of the 2 lowest lecture quizzes on mastering. You get the most benefit if you have 2 zeros. Okay, so the bigger the slacker you are, the more reward you get when I drop those lowest grades. So if you have 2 zeros, that's a greater reward at the end than those whose 2 lowest grades are a 9.1 and a 9.2. Okay, but either way, I'll go in and I'll drop those 2 lowest grades. And so I'd never like to have this conversation, but remember that tomorrow night at midnight is the last opportunity to drop the class. After that point, you get the grade. And so if you're on the bubble, come talk to me afterwards. Let's talk about how many points you need to get out of those remaining 175, okay, to pass the class. I'm no longer ranting. My rants are done. I've ranted with all 3 lab groups. I was a little bit more mellow this afternoon than I was on Tuesday. So with that said, we are halfway through the urinary chapter, actually more than halfway through, and I'll be finishing up urinary. We had finished really a lot of the meat of it, and those 20 terms that you're going to include, I don't know what's better. Those 20 terms that you're going to include on that short answer, everyone has those terms, knows what I'm talking about, yes? And I spent really about a third of the lecture last time talking about that body of knowledge that's important for that. And there was a figure in your book that you could turn to, essentially figure 24.9, and that figure is essentially, I'd say about 80 to 85% of a concept map that you could actually recreate to demonstrate your understanding of that 20-point question. It's actually worth 30 points. So 20 points, 1 point for each word being used properly, 10 more points for style points. So that's kind of subjective, but how well you put it all together, how neat it is, all that would contribute to those last 10 points. Then there will also be, as I said last time, some connection questions. So I will tell you and ask you to fill in with one statement, one sentence, the connection between 2 systems. So for example, it might say, name a connection between cardiovascular system and the urinary system. And there'd be a big blank there, right? And then you would tell me what? All sorts of things. Give me one reasonable connection between cardiovascular and urinary. Urinary is cleansing the blood, right? I mean, that's one pretty obvious one, right? Blood pressure connecting to urinary system. We got that. We know that ANP, atrial natriuretic peptide made by the heart, affects the kidneys. I mean, there's no end to the possibilities. If you leave them blank, I'm going to start ranting, okay? Because I don't think they're that hard. But to leave them blank would be rather disappointing. It's like, I don't even care. I'm not even going to think, because I'm quite confident with just a little bit of neuron power, you can figure these out. Make some connection. There are endless numbers of possibilities. Just have something there that makes sense. Fair enough? I also went through the last 4 exams and chose about 10 or so questions from each exam. I made sure those questions were big ideas. So there are going to be a few, well, there's about 60, I guess, of those multiple choice questions that I took from old exams. And you've seen it all before. And that's just kind of that cumulative portion. So the exam will be worth 120 points. 2 hours, testing center, make sure you've made your appointment. They'll be expecting you on Thursday or Friday of next week. If you can, you have to make your appointment. But if for some reason you want to take it Wednesday, let me know. I'll allow you to do that, but they won't let you take it unless I let them know. So you need to email me, and I'll let them know that Wednesday's okay. I wouldn't recommend any earlier than that, because I do want you to have some time to kind of rebound from the lab exam that's on Tuesday. Fair enough? Anything, any hanging chads, anything that you need to ask me about grade-wise, procedurally, anything at all? Exams next week? Lab exams? Tuesday? 4 to 6 or 6 to 8. And no lecture next Tuesday. This is our final lecture. There is a lecture on the reproductive system, actually two, one's short on the male, a little bit longer on the female. Those are posted for you. They are part of the regular portion of the final exam. You have 2 quizzes due next Tuesday night. By midnight, it is the urinary quiz. And on Wednesday night at midnight, it is the reproductive quiz. And after those are all done, that's when I'll go back in and manually drop the 2 lowest grades. But I can't do it until then. So you won't see those adjustments done until next week. Anything else? Okay, well, let's move forward. Are there any questions that you can articulate right now from what we've covered thus far? Stacy?
Can we go over the countercurrent multiplier?
That's where I'm going to pick up. So I'm going to pick up with countercurrent multiplier. So that's where we kind of got to, and I said that's where I'll pick up. So up till that point, let me go to that image. The image on slide. Let's go through this really quickly as a quick review to get our minds around this. The first 5 or 6 sections, again, were just anatomical review. Then we went through the physiology of the kidney, and by that I mean the segments of the neuron. That's anatomy. But then once we get through the segments of the neuron, then you need to know what each of those sections is doing, right? Is it filtering? Is it reabsorbing? Is it secreting? What's going on? That's where we're going to pick up the story right now with the loop of Henle, because that's where that countercurrent multiplier thing is going to be important for us. We talked a lot about these different molecules. Oh, and I also talked about this. So I'm pointing right now to this region of a glomerulus, and that region is collectively called the juxtaglomerular complex. And what is that? It's 3 things that come into close proximity. It's the afferent arteriole bringing blood in, the efferent arteriole taking blood out of the glomerulus, and the loop of Henle coming up and becoming the distal convoluted tubule at that place. And these 3 things come side by side. And what is going on there? What's the significance of the JGA, of the juxtaglomerular apparatus? Measuring the pressure in that particular nephron. Remember, you've got 2.5 million nephrons or so in your 2 kidneys. And each nephron is kind of auto-regulating its own flow. So what's the deal? Tell me. What is the measure of the flow of plasma through the glomerulus called? The GFR, the glomerular filtration rate. And recall, I'm kind of jumping around here, but remember that call that was about 125 mils per minute. Is that right? Yeah. And would be over a day's time 180 or so liters of fluid. That's how much the kidney must be constantly filtering your plasma. And it's measuring that. And it's making sure that it's doing its job. And it's doing that if the fluid volume, right? If the fluid volume in the loop of Henle and the fluid volume in the distal convoluted tubule is low, right? So the fluid coming back up through the distal convoluted tubule is low. That's going to send a signal. That low pressure, that low volume is going to be triggered at the JGA, and what's going to be released from those cells? Renin, right? Renin is going to be released from those cells in that JGA area. And what is that renin going to do? It's going to cause the afferent arteriole to open up. It's going to cause the efferent arteriole to constrict. And it's going to cause those mesangial cells that are wrapped around the glomerular cells to squeeze. Collectively, what is that going to do? Bring more blood into that individual glomerulus, keep it there longer because the exit has been shut down a little bit, and force more blood across the glomerulus. That should autocorrect, right? That should autocorrect what's going on here in that particular glomerulus. And all of your glomeruli are doing this, kind of self-regulation. But if that auto-regulation is not enough, and overall the kidney is not getting the job done, there's a greater kick-in that's going to happen. And that's when we're going to pull in the big boys. So I'm going to this picture. I'm going to jump down. That was in what section? That was in 20. There we are, right? Okay. So I'm going to go back. This is the auto-regulation. Okay. And in fact, I just misspoke because the auto-regulation does not include renin. Okay, I just misspoke. Renin would be when the big boys come in for the endocrine response. So even without renin, if the pressure is not enough coming into the JGA, then the kidney on its own will dilate the afferents, constrict the efferents, and contract the mesangial cells. That's local, no hormones. I apologize. If that is not enough, then we pull in nervous system and hormone signals. And that brings us to basically this image. And this image is critical to that 30-point written section on your final exam. And that is, if the autoregulation is insufficient to restore to the normal GFR, then we're going to kick in endocrine. This is where, now, the cells of the juxtaglomerular apparatus are going to kick out renin. Now, what does renin do? It's a hormone released by the kidney, these cells in this area. It travels systemically and does some amazing things. What does renin do? It specifically converts angiotensinogen to angiotensin-1. Right? Now remember the angiotensinogen word is not on here. I added it. So angiotensinogen is the molecule that's floating around in your blood all the time. It's made by the liver. It's kind of in the background, similar to the fibrin story that you know about from blood clotting. So this molecule's there all the time. And renin will form angiotensin-1. Angiotensin-1 will travel through the blood and will pass through the capillaries of the lung. And there, it's kind of weird, but there, the cells in the capillaries of the lung make an enzyme called ACE. That angiotensin-converting enzyme is more largely made in the lung than any place else in the body. As a result, angiotensin-1 is converted to angiotensin-2. Angiotensin-2 is an incredibly powerful vasoconstrictor. And so it goes about triggering an increase in volume, right? An increase in blood pressure. It constricts, many. It goes around and it squeezes many of the peripheral arterioles as well as squeezing on the efferent arterioles of each glomerulus. So that's only half the story because that angiotensin-2 also triggers the release of aldosterone. And aldosterone, as you know, is made by the adrenal glands. And that, remember, increases sodium retention. So think about what that means. If you retain more sodium, you retain more fluid. Retain more fluid, increase the blood pressure back. And angiotensin-2 also increases ADH and increases sympathetic motor tone. So we have a little bit of sympathetic nervous system kicking in. We've got more hormones kicking in. And we talked about ADH on day one, so you know that. Ultimately, what's going to happen is you're going to increase your cardiac output, you're going to increase your fluid, you're going to increase your blood pressure, and as a result, the kidneys will now restore their GFR. This is going on all the time. These are not just things that happen in disease states, okay? I think that's also important to think about. When we think about these physiological loops like this is not something that happens because, oh, Uncle John is sick. This is what's happening in your body all the time. I mean, your body is doing this magic of modulating renin and ADH and aldosterone all the time. It's when the body can no longer do this that we're really in trouble, right? So this is what's normal. This is what your body's doing, and when your body can no longer make these adjustments is when the kidney and the blood pressure issues become a problem. Okay. Is that making sense? Everything, I believe, nearly every word on that 20-word list is on this page except ANP, atrial natriuretic peptide, I think. And someone can confirm that for me right now. But is there anything else on that I didn't just say?
They can easily be added.
Right. I mean, the word sodium can be added in. The word water can be added in. Aquaporin. Oh, aquaporin is not on the list. Aquaporins are made in response to ADH. So again, it's not on here, but we got that connection. We've been talking about that. So I would say that 18, 17 of the 20 terms are right here on this. If you prefer to draw a concept map, make sure it's not just sodium, goes to urine. Make sure you tell me what it means. So a concept map and a paragraph are really no different. Because a paragraph reads in words, a concept map really should read the same way, except the words in the boxes have little linker statements that basically write the sentence. And so it's the same thing. A concept map is not easier than a paragraph. It's the same amount of information. It's the same expectation, right? It should make just as much sense as a picture as it does a paragraph. So you choose whichever one you want to do. You will have two sides of the paper to do this, okay? So on the test, I've got the 20 words at the top, then the page is blank. If you need more room, on the back side, I put the 20 words there again, just so you're not flipping back and forth. So you've got plenty of room, plenty of space to make this concept map or write this paragraph. I would suggest maybe that's the first thing you do when you get to the test. Flip it over. That's probably the thing that you're going to mostly want to dump, right? Memorize and dump. Not that you forget it, but you want to put it on paper as quickly as possible. Then the second thing I would suggest you do is go look at those connection statements and do as many of those right off the top of your head as you can. And then go do the test. And the connection statements that you could not initially think of will come to you during the test. Okay, so that would be my suggestion as an attack to this exam. This short answer portion first, the connection short answer part second, do the test, then come back, fill in any connections that you weren't able to come up with immediately. They're not worth that many points. I wouldn't spend too much time on them. You don't have to write a book for them. Just a succinct but specific connection between the two systems. Each of those is worth 2 points. So giving me garbage is worth a point, maybe, and giving me a specific detail, not in a paragraph, but a very slam dunk answer is going to be worth the 2 points. Okay, so that is moving through an important part of what we talked about last time as a quick review. And then we talked about the processes of reabsorption and secretion. And I'm going to pick up right here with the nephron loop at 2411, because this is going to bring us into the counter current. And I may not have to go back this far, but I'm going to start here and slow down a little bit. Anything at all that I've said? I think I was going to start at 2412, right? So I might be running through this rather quickly.
Yeah.
I might be running through this 11 rather quickly, but I want to start here to get our minds back into the nephron loop. Anything at all? Robert? Renee? Stormy? Chelsea? This is romper room. Okay. I see Kiara. Romper room. Okay. So the nephron loop. Where do we find nephron loops, ladies and gentlemen? Cortex or medulla? Only in the medulla, right? That's where the loops of Henle are. And what do we find in the cortex? Essentially everything else, right? The renal corpuscles, the glomeruli, the Bowman's capsules, the DCTs, and the PCTs are all up there in the cortex. And so the only thing coming down into the pyramid would be the loops of Henle, collecting ducts, and the capillaries around the vasa recta, the capillaries around those long loops of Henle. And where do we see those vasa recta? Only on the juxtamedullary flavors. And that accounts for what percent of your overall nephrons? 15. 85% of your nephrons are cortical. 15% are the deeper ones that have the vasa recta. And as I'm going through this conversation right now, you're going to better understand why there's two different flavors of nephrons. Okay, 85% are the corticals, 15% are the juxtamedullary. They're doing a slightly different job because you're going to see that vasa recta goes deep down into the medulla. Let's figure out why. So in the nephron loop, this thing called the countercurrent multiplier is there, and this causes trouble. I think I said last time, one of the issues with the urinary system is that rarely have I seen an artist's rendition include all of the details in one image that's necessary to really pull all of this together. You'll see a nephron, you'll see a vasa recta, you'll see the pressures or the osmolarities mentioned in the fluid through the gradient, but you rarely see one that pulls it all together into one steady place. So you got to put some of those pieces together yourself. Now, remember that when the loop of Henle goes down, there is the descending limb and the ascending limb, and the two sides do something different. But remember, they are connected to each other. They're very, very close in proximity to each other. In other words, some things that are going out on one side of the loop of Henle are going in on the other side. So there's this exchange going on. Okay, there's an exchange going on. And you've got fluids moving in opposite directions. You've got filtrate going down and back up, but what's wrapped around that what's wrapped around that loop of Henle? Vasa recta. And I want you to realize that there's blood flow going right down along that loop of Henle. And as we know, what leaves the blood goes into the tube, and what leaves the tube goes into the blood. So this is this exchange going on as that deep loop of Henle passes down through the medulla. And in those deep loop of Henles, it's the solutes, it's the sodium and the chloride ions that are put out into the medulla that help to maintain the salty medulla, right? That salty marsh. And why do we have to keep that marsh? Why must the medulla be so salty? What's the job of the nephron? To make urine, add things and take things away, and to concentrate that. Because remember we said, if we don't concentrate our urine, right, we're going to be peeing out 100 and some liters a day. So we've got to concentrate it. So in order to concentrate the urine, what happens? We go through the nephron loop, and then as that almost urine, is traveling down through the collecting duct, going through the medulla, what's happening? That salty marsh is pulling the last bits of water out of the almost urine, concentrating it. Okay, so just kind of getting all these things in our head as we move forward. And if we understand that, then looking at these figures will be so much more understandable.
So why is it that the capillaries around the vasa recta don't absorb all that sodium because of diffusion?
Okay, the question is how does the medulla stay salty if maybe those vasa recta capillaries would just kind of suck up all that? That's a good point. There's some regulation there, but there's so much salt in the medulla that it's just too much. Okay, let's just think about it that way. So, the thick, and I remember I had these backwards. I'm going to skip ahead. There is the thin descending limb. I just think it's easier to go in order. So as the filtrate's coming through, there's the thin descending limb. And what did I say about this limb that's going down? What could leave? Water. So water can leave on the way down. What cannot leave? Electrolytes, sodium. That means that as that filtrate comes down the tube toward the bottom, what's happening to the osmolarity, the concentration of the tube fluid? It's increasing. It's becoming saltier, higher osmolarity. But then as we round the bottom, it says around 1,200 milliosmoles. As you round about the bottom and come back up, what's now happening? The water can no longer get out. Now, only the sodium and the chloride can leave. Seems counter intuitive again. Now, the water can no longer leave, so now the sodium's leaving. So as that fluid climbs back up, what's happening to that fluid? It's becoming less concentrated again, isn't it? And so the solutes are leaving. Well, as the solutes leave, that's helping to create that marshy saltiness. So the question was, why don't these ions get reabsorbed? Ions are charged. Okay, sodium plus, Cl minus. And that charge makes it more difficult sometimes for uptake. What do we know about uptake? Let's go back to maybe Biology 105. Can an ion get across a cell membrane? Easily. What can get across a cell membrane easily? Things that are, think back to the steroid conversation too, things that are hydrophobic, things that are fat-like can get across a cell membrane. But things that are highly charged, like ions, are not going to be quickly reabsorbed into across an epithelial layer unless there's a mechanism for that to happen. So what's happening here in the loop of Henle is that the water, we know water moves really easily. So the water that is spit out of the descending limb is welcomed back into the vasa recta capillaries. But the electrolytes that are spit out on the ascending limb are not readily accepted back. Okay, so that brings you back to your question, Stacy. So that still leaves what? It leaves the medulla very, very salty. Okay, hold on to this. So we have the thin descending limb. It's permeable to water, not to solutes, versus going back, the ascending limb coming back up, which we said was impermeable to water, but did allow electrolytes out. So looking at those pictures just to get the idea of this. So as this is the fluid coming down, so this is the descending limb, and what's coming out? What's coming out there? Water, right? So water can come out on one side, and on the other side, what can come out? Sodium. Now, what's missing here, folks? What's missing here, and again, no one picture shows everything, unfortunately. What's missing is that there's vasa recta wrapped around that loop of Henle. So the water that's coming out here, this water is being brought right back in to the vascular system. Okay? But the sodium and the chloride that are being spit out are not being welcomed back in as much.
So this is happening in the juxtamedullary.
This is happening primarily in the juxtamedullary. Absolutely. Because, exactly. So this loop of Henle that goes so deep down into the medulla, this is primarily the loop of Henle's of juxtamedullaries. So what we argue then is that it takes 15% of your nephrons to keep the marsh salty, right? The big extra job of these nephrons, these juxtamedullary, is to keep the salty marsh. The 85% really don't contribute to this, but the 85% are all busy doing what? Reabsorption and secretion. That's very actively going on in the cortical nephrons, but the juxtamedullary nephrons have this extra job of keeping the marsh, the medulla, very, very salty. Is there anything there that I'm saying that's like, whoa, what in the world are you saying, Mac? Is it beginning to click in? This is one of those things, it just takes, you got to hear it a few times. So look at this image again. Coming down, the filtrate is at 300 milliosmoles. Remember, that's just a number that is related to the concentration of the stuff, the solutes in the urine. I said urine again, in the filtrate. Coming down, it's going to get bigger, higher and higher and higher, down to 1200. Again, water's coming out on this side. What's missing again? Again, we're not seeing where that water's going. That water's being taken right back up by the vasa recta. Then on the other side, on the ascending side, here you see sodium and chloride are going out. And notice it says pumped out. What does that suggest? Active, right? Ions do not move across a membrane without being transported. They're actively or somehow energy is involved in getting ions across a membrane because they're charged, right? They cannot slip through a membrane without help. And that always requires, most of the time, active transport mechanisms. So you've gone through the loop of Henle, and you come back up. Even if you didn't go through a deep loop of Henle, right? Picture now for a cortical nephron. Even if the filtrate only goes through a wimpy loop of Henle down a cortical nephron, and maybe it doesn't get quite as concentrated on the way down and on the way back up, still that urine, that filtrate, is going to travel through a collecting duct, right? And you're still going to have the opportunity to concentrate that urine as the collecting ducts pass through that salty marsh. So that brings us to this picture, and that is, no matter what happens, as you go down and back up the loop of Henle, you're always going to be passing back down through that collecting duct. And here you can imagine water is being pulled out. Now, what is going to cause more water to be pulled out? ADH. Okay? Now, why would the body pull more water out of the collecting duct? Because the body says you are dehydrated. And when you're dehydrated, your body produces ADH. ADH is going to directly cause a protein called an aquaporin to be stuck into the membrane of the collecting duct. And what does that aquaporin do? It's an ion, it's a protein that's porous for water. Recall that water can get across the membrane anyway. Do you agree? Water can get across the membrane. It's weird. We wouldn't think water could because water is polar. You wouldn't think water could get across the membrane, but it's so small it does. So what do these aquaporins do? Increase the amount of water that will naturally go across the membrane. So your body is dehydrated, it produces ADH. ADH causes more aquaporins to be placed in the collecting ducts, and as a result, more water is pulled out of your urine, and the urine becomes more concentrated. Where does that water go? Again, that water, even these collecting ducts are surrounded very, very closely, proximity to vascular supply. So there's going to be that water is going to be taken back up by the body through those capillaries. And that's kind of where we got last time, isn't it? Okay, how are we doing? Reasonable? Okay, so let's keep going. So there is an obligatory water reabsorption. This kind of comes back to day one as well. Remember that there's an obligatory amount of urine that you must leave every day. Your kidneys must be working to maintain your physiology, your homeostasis. And so there is an obligatory water reabsorption. This happens without hormones. Okay, 85% of the water that goes into your filtrate will be automatically obligatory, right? Obligated to be reabsorbed. So that means what? Really, your body's only playing with 15%. If you're pushing water all the time and you're very, very hydrated, you will pee a lot more than your neighbor who is not well hydrated. And this all comes down to the hormone levels. The hormones are really only playing with this 15%. Why? Because the kidneys will, by obligation, obligatory, will reabsorb 85%. Now that's going to happen in the proximal tubules and on the descending side of the nephron loop. 85%. That cannot be adjusted. That's not open for negotiation. If the body needs to hold more water, then we're going to have facultative water reabsorption. Think it's being facilitated. Something's going to help it, right? Facultative, if you've taken microbiology, you know facultative organisms are ones that can kind of go either way. So there's some decisions that can be made. So facultative water reabsorption, this is going to occur in the DCT and the collecting tubules. This is precisely controlled, and we know the players. This is ADH and aldosterone. So those hormones are going to help figure out what's going to happen with that 15% of the filtrate. So this figure is showing us that the obligatory water reabsorption is what happens on the left-hand side of this image. Everything on the left-hand side of this line is obligatory. Where does the nephron automatically pull water? It pulls water through the PCT, and it pulls water on the downward trend on the loop of Henle. If, after that, the body needs to collect more water, now it's facultative. This was 85%. 85% of all the water will be reabsorbed in this side. The other 15%, if you're well hydrated, it's going to go. You're going to urinate a lot. If you're dehydrated in any way, then the body's going to collect that water back, and it's going to do so throughout the DCT and throughout the collecting ducts. And that's going to be hormonally regulated. Does that make sense, that concept?
So you're saying that on the PCT on the first side.
Yep, that is obligatory.
And the other
Is facultated or facilitated, yes. So what that means is the kidney's going to do the left-hand side regardless of your body's hydration, regardless of hormones being produced or not being produced. That's the function of the kidney. 85% of your water will be reabsorbed. The other 15% is what the body plays with.
So this is all so that our body has the last chance before we ever urinate to get whatever water back or whatever water we don't need out.
You got it. This is the body's way of regulating that we keep the water that we need We need to keep it to maintain our blood pressure. We need to keep it for all those reasons, right? Renin and blood pressure to the kidney and all these things. But if there's plenty of water and renin, the kidneys are happy, and your osmoreceptors and your hypothalamus are happy, and you're not thirsty and ADH isn't being made, then you're going to flush that last 15% of water out. Okay? The kidneys are beautiful. It is beautiful. A little bit complex, right? We got to put our mind around it, but wow, it's beautiful.
So that means when you drink alcohol, it's only that 15% that's affected?
Yep. When you drink alcohol or drink caffeine or consume anything that's a diuretic or even take Lasix or take any kind of diuretic, the kidney, if it's normal, healthy, is going to take care of that water 85% up front. It's the diuretics, it's the alcohol, it's the caffeine that still is playing with that 15%. It's not going to mess around with that first side. Okay, that 85% is obligatory, right? Obliged. It's going to happen. So, urine volume without ADH. If there's no ADH, Stormy, what did you just tell me? If there's no ADH, then the water is not going to be reabsorbed in the DCT or the tubules. It's just going to keep on going. There is no facultative water reabsorption. Therefore, that 15% is simply part of your urine. And you will have large volumes of output, and that volume will be low in solutes. Another way of saying it, the volume, that urine will be low in specific gravity, right? You'll have very few solutes. Your specific gravity would be close to pure water. Not perfect, but close to 1.000. So what are we seeing here? Again, this is just a cartoon of this. If all is well, okay, if all is well, and this, I don't know, it doesn't show up that well. No matter, if you're drinking lots of water, and all that water is being pulled out through the DCT and the downward loop, or sorry, the PCT and the downward loop, then the other 15% will simply be part of your urine, and you will have high output. If, however, your body is dehydrated, now, or low blood pressure, right? It doesn't have to be just dehydration, because what did we just say? Renin is released when your blood pressure is sensed to be too low. And renin, angiotensinogen to angiotensin 1, ACE to angiotensin 2, angiotensin 2 drove up aldosterone. Aldosterone also helped to pick up ADH. So you could have low blood pressure, which is also going to kick up your ADH. If you have low blood pressure, what your body want to do? Increase it by increasing your fluid level. So no matter the mechanism, if there's ADH involved, this is where the aquaporins come in. ADH is going to cause these aquaporins to suddenly like pop into the membrane. And I talked about them last time. I said they're sort of like those orange straws, those things you pop into the orange and you suck the juice out. That's how I picture these aquaporins. I picture them as these little protein pores that pop in, but only when there's ADH around, right? And water moves through those aquaporins and is reabsorbed. These are found, again, where do they stick these aquaporins in? DCT and collecting ducts. So here, in this picture, where it says ADH going in, picture that ADH as basically being one of those, straws, right? That you suck the juice out of the orange. And so that's going to cause more aquaporins, and that's going to cause more water to what? Come out of the urine, I said it again, out of the filtrate, making your urine more concentrated. So ADH is on that table of 20 terms. Normal urine, don't worry about the numbers, but normal urine volume, about 1,200 mils a day. 1,200, 1,500, 1,800. You'll see different books in different places, different numbers in different books, but in that range. And it varies from day to day based upon your diet, based upon your activity, based upon the weather outside and how thirsty you are and how much you drink. But still, it's roughly 1%, isn't it? It's 1% roughly as a catch-all. So your body is going to reabsorb 99%, allowing you only to urinate out about 1%. So last time I told you, average male, about 180 liters a day of filtrate would equate to about 1.8 liters of urine released in a day. Smaller person, about 120 to 150 liters a day. Again, giving you 1.2 to 1.5 liters of urine a day. Again, roughly 1%. Your body is recapturing 99. In lab, Stacy is going to throw a green marker at me or something else, or at least give me some strong looks. Because in lab, what did I tell you the normal pH of urine was? In the lab manual, it said 3 to 7, right? Acidic up to neutral. And here I'm telling you that the normal range of pH of urine can be up to 8. So again, don't get crazy with me. Different norms, different books. But typically acidic up to neutral area. Specific gravity, that number is consistent, 1.003 to 1.030. I'm not going to have you worry about the osmotic concentration numbers. The concentration, the water content's really high, like 95 or so % of your urine is water. And there's your volume, 700 to 200 mils a day. Again, that's all based upon your own intake and your own metabolism. But do you remember in lab day 1, what is the obligatory water loss? There was a number thrown around day 1, lecture 1, and it said that the body must produce at least 500 mils of urine a day. That 500 mils is thought to be the minimum urine production, because without releasing 500 mils, even if it's super concentrated, without releasing 500 mils, what are you not doing? You're not cleansing the blood, right? So you've got to be obligatory releasing about 500 mils. That'd be the bare minimum, and we see here an average of 700 to 2,000 a day. It is thought to be sterile. It depends. If you have any sort of infection, then it won't be sterile, obviously, if there's an infection of the urinary tract infection of the tract, or even as the urine passes out by the epithelium, there are going to be bacteria that are going to hop a ride. So to say that urine is sterile is not true. However, where is it sterile? Not even urine, but the filtrate better be sterile. Do you agree? Because your blood better be sterile. Sterile meaning no bacterial infection. So there better not be any bacteria in your blood. Therefore, there shouldn't be any bacteria in your filtrate going through the tubes in the loop of Henle and out through the minor calyx. At that point, there should be no opportunity up until that point for bacteria to be in the filtrate. Now, once it enters into the urinary tract, the ureter and down, there's always the possibility of a UTI, an infection, in which case the urine would not be, quote, sterile. Okay? But by and large, urine is not going to hurt you. And you may have heard me say before, urine has uric acid in it. And if you look at any of your heel, any of you ever put any cream on your heels, right, to get the calluses off and sort of soften the skin, elbows and heels, it's got uric acid in it, right? So basically, if you pee on your elbow, it'll soften it up, right? So it's not going to hurt you, okay? It's really not most of the time going to hurt you. Okay, with that said, any questions on that? Any questions on anything I've said, right?
So we should lick our wounds.
Lick your wounds and pee on your elbows, yes. And that's not easy, but yeah. Speaking of salt, I'm drinking this Propel water. Anybody ever had this Propel water? It was on sale, so I grabbed it. Made by Gatorade. It says on the nutrients that it's 2 servings of water, reasonable, 0 calories, 0 fat, 0 protein, 0 carbs, all the normal things. But it's made by Gatorade, so they put some electrolytes in it. By drinking this bottle of water, I am getting 15% of my sodium for the day. This is salty water.
They want to make you thirsty.
It is salty water. It is. I was surprised at how much sodium they put in that water. And now when I think about it, it actually does taste kind of salty. So salt is everywhere. Okay, 2413, renal function. I mentioned last time, nephrologist, urologist, when they're talking about the kidney, will not be talking about any one individual of your millions of nephrons. They talk of the kidney as being one large nephron. So they're going to talk about everything sort of being, the same. Do you agree that the filtrate, what comes across the glomerulus, should have the same electrolyte concentration as plasma. Because what's going to get through those little cracks in the fenestrations of the glomeruli are electrolytes. So the concentration of electrolytes will be essentially the same, except for plasma proteins. Right? Plasma proteins are usually too large to get into the filtrate. So everything else is pretty much the same, except for that. Tell me again, what happens in the PCT, proximal tubule? Ions, organic nutrients, fancy word for things like glucose, water, are all going to be grabbed up and reabsorbed here in the PCT. And remember, continuing water will be reabsorbed as you continue down the first side of the loop of Henle. So in this figure, it's just reminding us that as blood comes in and goes around the glomerulus, that 300 number is referring to the stuff that's in the blood as well as what's in the filtrate. And we've seen that 300 number show up a few times. And we know that as we go through the proximal tubule and down the loop of Henle, that number goes higher as that becomes more concentrated. Now here, for the first time, what this doesn't show, again, these never show everything, this is going to go back up, isn't it? Okay, that is the filtrate. Finally, they're showing the vasa recta next to the loop of Henle. So I alluded to this earlier. The water that's coming out of your tube is being welcomed right back into the vasa recta. This is part of that countercurrent thing again. Because look at the directionality here, folks. Look at the arrows. I'll clean it off, and I'll make big red arrows. I'll make big purple arrows. This is the direction, oh, green. That's the directionality of the filtrate. This is the directionality of the blood flow. Counter current. Okay, so that word counter current is in part referring to the fact that the filtrate and the blood are traveling next to each other in a counter current way. Then, this is still review, what happens as we come up the ascending limb? At that point, water can no longer be reabsorbed, and now only sodium and chloride are being pulled out. The DCT and the collecting ducts are going to make the last adjustments under hormonal control, and the vasa recta, right, that capillary bed, is really the one responsible for maintaining the marsh, isn't it? The salty marsh is really the job of the vasa recta and those deep loops of Henle. So here's the other side of that image, basically. Now we see that this is coming up from the Nephron Loop. And what was coming out here? Remember, we had sodium and chloride coming out, and some of that, not all of it, but some of it will be absorbed, but it does take work for this to happen. And notice that there's also sodium sometimes being released and removed from the collecting ducts. Again, this is all under ADH regulation. So the more ADH there is, the more water that's being pulled out.
When it talked about potassium being exchanged and hydrogen being exchanged, where does that happen?
Okay, hold on. Potassium, okay. What are the two ions that I told you were actively being secreted? One, acid. We've dealt with that one a little bit. The second one is potassium, and I'll get to that in a minute. Okay, that's also happening a lot in the distal convoluted tubule. Okay, you're seeing it right here. There's potassium right there, and here's potassium right here, and that's happening again on the other side, mostly on the DCT side. So finally, here's a picture. I know it's too small to see on the PowerPoints, but this is the first time that everything kind of starts coming together to see this countercurrent idea, that the filtrate's traveling down the loop of Henle, and next to it in close proximity is this vasa recta. Now, of course, this is highly simplified, but it gives you the overall sense of what's going on. Is this figure, the big ideas make sense here? And we need to be tutored through this.
I get where the countercurrent part comes in. I don't understand the
Countercurrent simply
I get
means.
That, but what's the
Okay, multiplier.
multiplication?
Okay, so the countercurrent part, I just said the arrows are moving in opposite directions. So you're going countercurrent. You're going against the flow. Multiplier means that the deeper you go down in the medulla, the more this happens. The effect gets multiplied.
Okay.
Okay, so the countercurrent is referring to the flow direction. The multiplier is saying that the deeper the loop of Henle goes down into the medulla, that the deeper you go, it kind of multiplies this effect. Okay, horrible word. I mean, it's an awkward term. So that's the other thing about the urinary system. Countercurrent multiplier is an awkward term. Secretion itself is an awkward term. It does not conjure up images of what it is in the kidney. So what happens with renal failure? Okay, when the kidneys can no longer perform their normal function, they're not filtering the blood properly, they're not reabsorbing and secreting properly, or they're not able to release their proper volumes properly, we definitely have a big problem. You're beginning, I hope, to really appreciate how critical the kidneys are to your overall well-being and why one cannot live without them unless you're on dialysis, which is an artificial cleansing of your blood. So if you have renal failure, yes, obviously you're going to have reduced urine output, but you're also going to have disturbances in your fluid balance. Makes sense. You're going to have issues with your pH of your blood. Makes sense. We talked about secretion of acid. You're going to have issues with muscular contraction. Why? What are we talking about here? Sodium and potassium, sodium and potassium. So if your body's electrolytes are out of whack, that would also affect your ability to have normal muscle contractions. We're not going to go back and revisit all that, right? But remember how important sodium and potassium were. Resting membrane potentials and action potentials and all that stuff would be affected. So your overall contractions of muscles, your overall metabolism, your digestive functions, hypertension. If you're not getting rid of the urine, the fluid, then you're going to have that fluid staying on your body, raising your blood pressure. You could very well become anemic because the kidneys, when they're in failure, are no longer making EPO. Erythropoietin is necessary to keep your red blood cell count up and to keep you from being anemic. And, again, connected to the electrolyte problems, you're going to have issues with your central nervous system. So, seizures, delirium, sleepiness. Now, these are on the extreme end of things, but absolutely your central nervous system will be hugely affected by the electrolytes and the pH, both being out of whack. Now, this does not happen overnight. Renal failure is a chronic type condition that happens slowly over time. Typically, the progression can be slowed, but it's like anything else. It's like the tread on your tire. Once it's gone, it's gone. And all you got to do is try to hold on to a few more hundreds of miles before it blows. So you've got to hold on to the kidney, what you've got. If you are in renal failure early stages, your doctor is going to be watching very carefully your water intake, your sodium intake, and your protein intake. Even for young people who are drinking power shakes with 30 and 40 and 50 and 60 grams of protein can develop kidney problems. More short-term than long-term, but overloading your kidneys with protein also makes them work harder. So, it's balanced. So these guys drinking 100-gram protein shakes, right, that can be a little bit troubling for the kidney, but that's kind of an aside. So by restricting the water, the salt, and the protein, you're actually kind of making it just an easier life for the kidneys, right? They're kind of going into retirement. They're in their last couple years, and we want to make it life easier on them. Now, what's also going to do is because you're taking in less protein, you're going to produce less of those nitrogenous waste. Remember I told you at the very beginning, uric acid, urea, ammonia, those were all metabolism products from your diet. So by having lower protein, you're actually minimizing the waste products that the kidney has to produce. Again, a major issue for renal failure is acidosis. So your blood pH is going to go down, and that has effects on muscle and central nervous system and on digestion and everything else you can imagine. What do we do to counter that? ingest bicarb. You've heard bicarb throughout the course here and there. Sodium bicarb is basically going to help neutralize. You have an upset stomach, you're going to take Tums, and that's full of sodium bicarb. So bicarb is going to help neutralize some of that low pH and take away some of that issue with the acidosis. Now, that's chronic. Acute renal failure, something that comes on very, very quickly, and this is going to be a sudden stopping or dramatic slowing of the blood flow through the kidney. This is going to be mostly trauma, okay, damage, some sort of accident, urinary obstruction, kidney stone, right? That's an abrupt stop to the flow of urine and production of urine. It could be renal ischemia, meaning what? Ischemia is a lack of blood flow to an organ. So for whatever trauma reason, right? Maybe you got hit and the renal vein or the renal artery got damaged or the kidney got damaged. That could lead to ischemia. Part of the kidney would die off. So that would lead to an acute problem. Or there could be exposure to toxic drugs. Some drugs are known to be nephrotoxic. They are known to damage the kidneys. Those of you know my story on the gentamicin took out my inner ear, or my inner ear, but gentamicin is also known to be very nephrotoxic. So as a result, I do not take any more aminoglycosides, the medication like gentamicin, because it's known to be cumulative. And so if I were to have 1 or 2 more doses of gentamicin, it could now destroy my kidneys. So I'm very, very careful. Many times these medications that are toxic are cumulative, and there's a threshold. And under that threshold, everything is fine. Over that threshold, boom, you've got major, major kidney problems. There could also be allergic responses that could also kick in on an acute basis to hurt the kidneys. Now, oftentimes this will recover, okay? These will recover, spontaneously recover, not all, but at least get you back up into normal kidney function. So an acute attack, renal failure, can usually be reversed.
Not like if nephrons are damaged, they can't be like rebuilt?
No. The nephrons themselves, once they're blown out like capillary beds, capillaries can repair themselves a little bit, but not very much. Nephrons, as far as I understand it, when they're gone, they're gone. Now, think about it. If the nephron itself is destroyed, but what if the flow to those nephrons is blocked? That would be the acute renal problem, but fix the blockage, the nephrons are okay. So that's where your chance of repairing the kidney has a lot to do with the cause of that acute damage, right? And but as long as the kidney, the nephrons themselves have not been damaged, they likely will recover. If during that short period of time, during the acute phase or at the end of chronic renal failure, the patient must go on hemodialysis or dialysis. You'll just hear dialysis. Hemo means blood. So this is the filtering of your blood across a membrane. And this is going to use a big artificial membrane to basically filter out your blood. And the membrane will diffuse and do basically what your kidneys do and return back what it needs to return back, just as if it were your kidneys. The problem, the issue is that people who are on full dialysis, there's a couple different types, but the more traditional dialysis requires that you go to a dialysis clinic, requires that you go in 3 times a week. Usually you'll be there Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Your kidneys have essentially shut down. So you're already on water restriction. You're already on protein and salt restriction. So your diet has been dramatically affected. The moment you go on dialysis, you are almost, as I understand it, automatically determined to be long-term disability and on some sort of disability. The process takes an hour or 2, and after the process, the patient feels rather drained. I mean, they've had their blood drained out and put back in. It's a rather draining, literally, experience. And then the night or so before they go in for the dialysis treatment, the acidosis is increasing, and so they feel kind of lousy. So it's not exactly a fun life, but it is one where life can be sustained for years. Also, the line to take the blood out and put the blood back in, typically, the veins and structures get really weak from repeated puncture, and so these people have shunts put in. Basically, sort of little lines that are coming out of their body, so they just kind of plug in. So they basically have these IV lines hanging out of their body. These ports are put in so that they can more easily, with less painful, plug in basically and do the dialysis 3 times a week. My mother was on dialysis for a while. She had kidney cancer, and one kidney was removed, the other kidney just never recovered well, and so she was on dialysis for a number of years, and then she got a kidney later on as transplant. But in those years of dialysis, she went through shunts in both arms, and they wore out. They just kind of wore out, and then she had one coming out of her neck for a while, and that was the worst. But they've got the shunt coming out of the neck, so she had this line coming out of her neck, and she'd go to dialysis, and they just plug her in, and it was just kind of this unsightly thing coming out of her neck that was more cosmetic than anything else. So what does dialysis do? It does the same thing that your kidney does at the glomerulus. It really is only allowing small molecules and small ions to filter across. Big things like plasma proteins in blood are not allowed. Same thing. Pretty fancy how this is done. Look here. Comparative composition of plasma and dialysis fluid. I'm not going to worry about this one, okay? We're not going to worry about this slide today. This is the physical doing of this. In this case, we see the shunt or the port is here, so they've already got this extra help, if you will. So we're going to pull the blood out. It's going to go into the machine, and this fluid is going to help cleanse out. A lot of this is just diffusion, right? It's just concentration gradients. And as a result, the blood is taken out, cleansed, and then brought back in. So it's sort of like when you give plasma. You've got 2 lines, one out and one coming back in. So like I said, dialysis relieves the need. Your kidneys aren't working. It allows you to survive, but it's not a cure, right? You're not fixing your kidneys. You're simply allowing that person to survive. It's good. People can be on dialysis for years and years and years and years. And you can go on cruise ships, and cruise ships have dialysis units. You just have to pre-plan. So most cruise ships, especially the Holland America types, with more older folks on those cruise ships, they've got dialysis units downstairs. You travel. Most dialysis units will have some spots in their lineup for visitors. They want to know in advance, and you can just go in and and they start early in the morning. Some places are 24/7. They're so busy. Dialysis units are very, very busy. Kidney failure is a big problem in our society because diabetes and hypertension are the 2 leading reasons for kidney issues, and those are big in our society. If you're lucky enough, having been on dialysis for a few years, to rise to the top and get an artificial kidney, then you've got to deal with, you're no longer dealing with dialysis, now you're dealing with immunosuppression. So there's going to be a long, never-ending story here with a kidney transplant. Yes, you don't have to do dialysis, but you are going to be immunocompromised. So now you've got to deal with, rejection and or more often having troubles with your immune system. The last little bit is basically the transport. We're taking urine from the kidney down through the ureters. And as I recall, Stacy, would you go back to the very first slide? I think I said to review 15 on your own on the cover slide for the chapter. 15 sounds familiar. 15.
16.
Yeah, 15 and 16. So going over the basic structures of the bladder, going over the basics of the ureter and the urethra. Okay, I'm going to flip through those. That's 15 and 16. And then we'll look at the last piece together, and that is the overall control of urination. So you know what the urinary tract is. You can look at overall kidney function with a pyelogram. A pyelogram is going to be able to visualize the fluid. Basically, they give you almost like a radioactive fluid. You drink it, and now your kidneys light up, and your ureters light up, and your bladder lights up. And so that can be very useful to see the proper flow. So you know about the overall structures. This would be a pyelogram. You're looking at, it's computer enhanced. But you can even see, it's kind of cool, where would the fluid be? And you can even see in here calyces. But you can see the flow of urine going into the renal pelvis and down the ureters to the bladder. The urethra, we call male and female urethra, same function really, just the passage of urine. The male urethra, of course, having the added function for the passage of semen. Female urethra shorter than males, pretty obvious stuff. You can review that. The bladder is actually anchored partially in your peritoneal cavity on the bottom, on the one side, by some umbilical ligaments. These are interesting. So the umbilical arteries, those structures that travel through your body connected to your mother during fetal development actually have another job. They actually help to anchor the bladder in place. The bladder has on the inside rugae, looks a lot like the inside of the stomach, sort of that ruffled appearance. And there are openings for the two ureters coming down to drop the urine into the bladder, and then there's the urethra carrying urine out. The trigone is this triangular area in the inside of the bladder. It's sort of an artificial thing, but it's the 3 points. 2 points for the entering of the ureters and 1 point for the exit of the urethra, and it actually acts like a funnel of sorts. So in this picture, the trigone is simply this triangle. Okay, and what you have is urine coming down the ureter, and it doesn't drop it in up here. Instead, it drops it in here at this opening, and then down here to this opening.
So do the ureters connect in the bladder walls until it goes inside?
Do the ureters? Yes, they connect to the bladder wall and then, travel down and enter in. Yes, yes. And other thing, here's that umbilical ligament. You've seen it on the models, perhaps, but these ligaments are what is helping to hold, and there's more, not to memorize it, but there's some of these kind of cool that something from the fetal development comes to hang out and help us in our adulthood. The ureters are layered, of course. There's a mucosa. When you looked at your urine yesterday or today or Tuesday in lab, you saw those epithelial cells. Some of those epithelial cells could be transition epithelium, right? The transitional type that is coming down through the bladder. Remember, the bladder is lined by a transitional epithelium. So is the ureter, lined by transitional. So what you saw under the microscope was transitional and probably some squamous as well. I'm not going to have you worry about the histology of that. The bladder wall has the detrusor muscle. Do you remember what detruse means? To force away, right? So this is the muscle that's going to help squeeze and force away the urine. And the urethra also has cells, stratified squamous, and that's what you saw in your urine sample. So that's just all review. Last thing, urination itself. It is referred to as the micturition reflex. Okay, micturition is another name for urination. The reflex, this is pretty coordinated. It's much like, in a way, swallowing. There's two parts to this reflex. There's the local reflex pathway, but then there's the central nervous system that plays a role in urination. So clearly there's the urge to go, and then there's the conscious release of urine. So these two, the involuntary and the voluntary part of your nervous system, come together to help coordinate urination. Locally, or I should say, another way of thinking about it would be involuntarily, the bladder, as it is filling, is going to stretch, and there are stretch receptors. And this is usually going to begin to stretch at around 200 mils of urine. So somewhere around that point, you're going to become aware that you need to run to the restroom. And these signals are traveling down your sacral area of your spinal cord. Parasympathetic nervous system is going to stimulate the detrusor muscle to compress the bladder. And that's going to increase that pressure even more. Now, once that begins to happen, there's also going to be, obviously now you're becoming conscious of this, so those signals must go up your spinal cord, go past your brainstem, and go up past your thalamus to your central cortex. And this is going to send signals for your brain to now control the voluntary relaxation of the sphincters. Recall there are two sphincters. There's a sphincter at the top, I should say, at the bottom of the bladder. There's a sphincter. That's your internal sphincter, smooth muscle. And then the external sphincter is a little further down in the urogenital diaphragm area, and that one is voluntary muscle.
We need to know about the projection fiber.
No, the projection fiber just means that there's information going from, right? Projection is like the pathways. So the pathway goes from the bladder up your spinal cord. That's the pathway, right? And it projects up to, and the fiber there refers to axons. Right? So those are axon fibers projecting up to your central nervous system. So taking a look at this then in a cartoon representation, the bladder is going to fill. As it begins to fill, it's going to stretch the cells, and stretch receptors there are going to send a signal. Those stretch receptors are only going to go as far as the sacral region of the spinal cord. And the parasympathetic nervous system, again, still very much involuntary, is going to help regulate that. At some point, though, it's going to start to squeeze on that detrusor muscle, and that's really going to give you that urgency to go. I mean, it's like, I really have got to go. You still got control over it. When it gets to be really bad, though, what's going to happen is that signals are going to travel up. This is that fiber traveling up. It's going up to the brain, and it's going to go up through the thalamus and go up to your sensory strip, and then there'll be signals coming down from your motor strip, and those signals coming down are now going to allow you to relax your external sphincter. And that does bring us to the end. The last couple words are problems with urinary diseases. Poly means what? Polyuria would be excessive urination, a sign perhaps of diabetes. Oliguria, oligo means a few or reduced or deficiency in. So oliguria means your output is lower than it should be. 50 to 500. What did I say 500? 500 was the obligatory minimum. So anything under 500 but not completely shut down would be oliguria. And then anuria would be a complete lack of urination, 0 to way, way low. It's saying here 50. If you're way down there, right? If you're oliguria or anuria, then you're definitely got some serious kidney problems. Now, it could be a kidney stone. It could be an acute issue. It doesn't have to be a chronic issue. But something is dramatically affecting your kidneys. If you are having trouble with going to the restroom, you could have some increased urgency. We see that on the TV all the time, right? The little bladder walking the woman around. So that could be some overactive bladder, or that could be some incontinence issues, leakage issues, the inability to control those sphincters. I have a friend, he's an OBGYN, and all he does all day is deal with women who are incontinent. So all day he's working with women in their pelvic floor and trying to strengthen the muscles, and I mean, this is a big deal. This is not uncommon at all, certainly more common in women. And if you are retaining too much, then you're going to have issues with blood pressure, but also this is more of a problem in guys. Women have usually overactive bladders. Guys will typically have urinary retention because the prostate enlarges, and the prostate can reduce the flow, make it painful, make it less than sufficient. Pain, right? Pain from kidney problems, typically lower back, lumbar region, and it gets much worse if it is the higher it goes. So the higher it goes up into the kidney area, the worse it is. Dysuria would be what? Pain or painful or uncomfortable urination. Again, usually enlarged prostate or urinary obstruction of some sort. And you can imagine dysuria, that discomfortable, what's going on upstream, what's going on. Kidney stone, something's blocking the flow of urine. Edema, if edema occurs when renal disorders lead to proteinuria. Protein in the urine, what's going on here? fenestrations perhaps, and if there's extra protein in the urine, why is it saying edema? Why would protein in the urine create edema?
Because there's not enough.
If the protein's in the urine, that means the protein's no longer in the blood. If there's low protein in the blood, solutes can't suck the water into the blood, and therefore water will be retained in the interstitial spaces. So that will lead to edema. Everybody got that connection okay? And if there's a UTI, then those bacteria can certainly lead to a fever. So you could have rather significant, if the infection goes all the way up to the kidney, I want you to picture this. If the bacteria, right, they started in the urethra, and they made their way up the urethra, up through the bladder, up through the ureter. If that infection gets all the way up to the kidney, and you have pyelonephritis, what could happen? Destroyed, very painful, huge kidney problems, but those bacteria are a fenestrated capillary away from entering your bloodstream. So there would be, in a worst case scenario, the possibility of a kidney infection progressing to the point of actually becoming systemic. Okay, because that is it's an open route, if you will, to the bloodstream. And that brings us to the end of this chapter. I've got just a little bit left on chapter 25. Let's take a few minute break, and I'll answer any questions about 24, and we'll move into the last little bit of acid-base regulation in a part of chapter 25. This last little bit brings us back to chapter 25, and this is where we started the semester with chapter 25, part 1 and 2. And this is where the first part was on fluid and water balance, obligatory water loss. Part 2 was on where sodium and potassium were normally found in the cell, sodium more in, potassium out, all that stuff, right? Then the third part we skipped over, and that was where we're going to head up now, and that is on the acid-base balance. And this will make so much sense now that we better understand the kidney. So it just says here, review 1 through 5, but you already know all this. This is sodium, this is water, this is ADH, the things that are now well ingrained in your head. The last little bit I want to go through is this acid-base regulation. We've been talking about how important the kidneys are in filtering your blood and also in the secretion of acid, and how that acid secretion in the kidney is helping to maintain your blood pH and fluctuates your urine pH as a result. So hydrogen is being produced. Acid is being produced by all of the metabolic processes of your body. That uric acid, the creatine, the ammonia, those were all waste products, and many of them are quite, not ammonia, but many of them are quite acidic. Lactic acid from muscles, we know that's coming from muscle use, and so your blood is constantly being bombarded with more acid. Some acid is being released by your respiratory system. We know that. The CO2 that is produced is being blown off as a waste gas. You are excreting hydrogen from your kidneys, and you also have buffers in your blood that are helping to store that hydrogen a little bit so that it can not affect your pH. There's a lot of hydrogen in your blood that is not immediately available to change your pH. In other words, this is like buffers. That's what buffers do. Buffers, like you add that big bag of bicarb to your pool or your hot tub, that buffer is going to keep the pH from fluctuating. So there's a lot of buffering power in our blood. The proteins do that as well. So if you look at this, in order to maintain your blood pH at 7.4, right, we're blowing off CO2, we've got that one. We're getting rid of hydrogen by secretion in the kidney, and where's all that coming from? Again, that CO2 and that acid is coming from the metabolism of your cells. What system is not shown here that also contributes to getting rid of a little bit of acid? Really not much. A little bit integumentary, a little bit of sweating, just a little bit, right? But not an appreciable amount. The kidneys and the lungs are the two biggies. So that means that the kidneys are getting rid of acids that are in liquid, and the lungs are getting rid of gas, right? CO2 gas. So let's talk about these different types of acids. There are fixed acids. acids, these are ones that can really threaten the pH balance of your blood. Fixed acids do not leave the solution. They are fixed. They can't go anywhere. They're when you fixation means keeping something in one place. These are going to remain in the fluids until the kidney excretes them. You cannot blow off a fixed acid, right? A fixed acid doesn't become a gas. It stays in solution and must be filtered out. And then examples of that would be sulfuric acid, phosphoric acid. If you've taken chemistry and you hear the word sulfuric acid, that kind of brings horrors to your mind because that's usually very strong acid. But you have sulfuric acid being made as part of your metabolism in low concentrations. And those would be fixed acids. Then there are organic acids. These are the acids that are being made by your cellular metabolism, like lactic acid. They're mostly being metabolized. So as you make them, your body finds another way to use them. So they don't spend much time accumulating. And then there's volatile acids. The acids. Volatile acids are the ones that are, if you think of something volatile, what's that word mean to you? It could erupt, right? There's a volatile fight, it could erupt, right? The idea here is that it can become a gas. So your volatile acids are the ones that can leave through the lungs. And an example would be carbonic acid. But remember, what can carbonic acid do, or what does carbonic acid do? It breaks down to, hydrogen and bicarb, and then that can also break down to CO2. So my point is that carbonic acid can become CO2, and then you blow that CO2 off. Where have you seen carbonic acid before? Remember this? H2O plus CO2 with the assistance of carbonic anhydrase becomes, H2CO3. So your body makes carbonic acid, water, and CO2 together. So here are those acids, right? You've got all these acids being made. Fixed acids, ones that cannot come out of liquid. Organic acids, not a big player here. And volatile acids, the ones that become gas. What's the pH of your blood? 7.4, plus or minus 0.05. So we're talking 7.35 to 7.45 would be a normal range. Outside of that, we're getting into some danger zones. And as you appreciate, if you play around with the hydrogen concentration, you're playing around with protein structure. You're playing around with membrane. You're playing around with enzymes. And those can have dramatic and devastating effects to both the cardiovascular and the nervous systems. pH below 6.8 or above 7.7, you're not here for very long. So tightly regulated. These are just some terms. I'm not going to go through those terms with you. You know all those terms. If you have too much acid, okay, then you have acidosis. This would be a blood pH below 7.35. Right? I said 7.35 to 7.45 was normal. If it's below 7.35, you have acidosis, or you are said to be acidemia. Have acidemia or be acidemic. Anything below 7, again, is deadly. Your CNS can't function below 7. Cardiac contractions grow weak. So it actually has a direct effect on the heart and the actin and the myosins of the heart, and it will drop your blood pressure dramatically. So very bad. Alkalosis is not much better. If you are up above 7.45, it's very dangerous. However, it's not very common. Because what is happening? Your body is constantly making acid. So for your body to suddenly have too much base is not very likely. That would have to be drug-induced or something. But this is not going to occur naturally in your body. Your body's always making acids. Your body is not making base sufficient to do this. We know the pH scale from long ago, right? 7 is neutral. Recall that things above 7 are basic, things below 7 are acidic. that means your blood at 7.4 is slightly alkaline, slightly basic. I still have some of you or your classmates who are still getting this reversed. And I know that from the quiz this week when I asked what happens when CO2 is blown into water. This is not a 50-50 guess, right? As CO2 is blown into water, when you take water and CO2 and you mix them, things become more acidic. If things are more acidic, the pH value is going down. I know you know that, but 30% of the class missed that on the quiz, okay? And you put the pH goes up. I think what you're saying is that the acidity went up, yes, but the pH value went down. You've got to do this mental cartwheel on pH. Now, we're going back to the respiratory system. You just said a moment ago, Stacy, you don't like the respiratory system. However, we're going back to it because PCO2, right? The pressure of CO2 in your blood, how much CO2 you have in your blood is going to have a direct effect on the pH of your blood. So, what condition is going to cause an increase in CO2 in your blood that we've talked about? What condition, respiratory condition, have we talked about that would lead to an increase in CO2 in your blood? Condition, disease. COPD or especially emphysema. Because what's happening in these conditions? You're not getting air in. You're not getting air in and out. And in emphysema, those alveoli have been blown open and gas exchange has been minimized. If gas exchange is minimized, your body is still making acid. Your body's still making the CO2, but you're not gas exchanging it properly. Not only are you not getting enough oxygen in, you're not getting enough CO2 out. So what's going to be one of the clinical signs of a person with emphysema? If you drew their blood and took the pH of their blood would be running acidic because their body is keeping too much CO2. Now, how can we fix that? We can put them on oxygen. We can help them with the exchange of gases, but they will still largely be acidic, okay? So there's that statement. There it is. If you missed it just a moment ago, CO2 combines with water to form carbonic acid, which is then carried through the body as H plus and bicarb. Does this make sense? An increase in PCO2 leads to a decrease in your pH. An increase in the amount of CO2 in your blood will lead to a decrease in your pH value. Conversely, a decrease in your PCO2 will lead to an increase in your pH. That's a very important statement. You should appreciate that, I think, from the respiratory chapter, but still, we're pulling all these things together. Uh-oh. Mac, you want me to remember this? pH, 7.3 to 7.45, right? 7.35 to 7.45. In order to keep your blood pH in that range, you've got to keep your PCO2 between 40 and 45 millimeters of mercury. Where did we see those 40 and 45s before? Remember these numbers? 40 was the PCO2 coming in to the alveoli, and 45 was the pressure leaving the alveoli. Or do I have that backwards? 40 is after, yeah. 45 coming in, 40 leaving, right? Sorry. But we've seen those numbers, right? And that's normal. And those normal numbers of 45 and 40 are going to keep your blood pH in check. And, again, if your PCO2 increases, that is going to increase PCO2 is going to drive your pH down. This is just a visual of the sort of equation I showed you a moment ago. Likewise, if PCO2 is going down, pH is going to be driven up. Your body has buffers. Again, those buffers are chemicals, molecules, proteins that are going to help keep the pH from changing. You want your pH to stay at 7.4. In order to do that, there are definitely fluctuations going on in your blood, and these buffers are going to basically, quote, suck up the H's, right? That's kind of how you want to think about these buffers. They suck up the H+. And if you suck up the H+, it's not available anymore to change the pH. So that's what buffers do. And your blood is specifically buffered to keep it at pH 7.4. Okay, don't worry about the weak acid conversation in here. That I'll let your chemistry professors, tantalize you with that. But just think about it. These buffers are sucking up the H+ and hiding them, if you will, from your body so that they don't affect pH.
So
The bicarb is, yeah. So, okay, I can say that much because you know that. Look at this equation here. It says what? Hydrogen plus bicarb makes carbonic acid. Okay, so what do hydrogen and bicarb do? They quickly chemically combine. Now that H+ is not floating around, and that buffers, keeps the pH from fluctuating as much. That's the carbonic acid. Bicarb is HC3CO3 minus. That's bicarb. And this is carbonic acid. What sucks up the hydrogen? Well, the bicarb. It recombines. The hydrogen is gone. It's hidden as carbonic acid. It's the H+ that causes the most direct problem with the pH. If you can disguise, hide, hocus pocus the H+, then it's not as devastating to the pH. So, what are the major buffers of the blood? This will help you with this. Again, what are you doing? You're binding up H+. You're hiding it. It's taking it away. They're not gone, right? They're not eliminated. They're simply hidden, reformed in a different place. And this keeps it from affecting the pH as much. You have in your blood phosphates. Phosphate buffers are huge. There's also protein buffers, and there's this carbonic acid bicarbonate. Basically what I just showed you is that H+ gets sucked up by bicarb to become carbonic acid. That is a buffering factor. It does take the H+ out of the equation. So you have these buffers everywhere. You've got phosphate buffers in your body, intracellular. You have carbonic acid and bicarb out of your body. Where do we have carbonic acid? That bicarb story was in the blood, wasn't it? Do you agree that the plasma of your blood is extracellular? And the phosphate buffering is happening largely inside your cells, intracellular. Then the protein buffers, those are also, they're in both places because you have proteins in your blood, like albumin, and you have proteins inside your cells that are also helping. So the proteins are buffering both inside and outside the cell. Amino acids are buffers. So amino acids are the building blocks of proteins, and they themselves can act as a buffer. Amino acids, by their very definition, have an amino group on one end and an acid group on the other end. And that chemistry, I'm not going to get into the chemistry of that, but the amino acids can suck up the hydrogens. That's all you want to think about. What can sponge up, what can suck up the hydrogens? Amino acids can do that. Okay, and that's going to help maintain that blood pH at its normal 7.4. Hemoglobin. Well, when we think of hemoglobin, what do you first think of? Blood and oxygen exchange and iron and heme groups, and that little story comes to mind. But it's interesting that red blood cells can also absorb carbon dioxide and also absorb, therefore, acid from the blood. We saw this a little bit. Remember there was that chloride shift story and how suddenly the bicarb could hide and come back, and that was one way that the body could transport acid. We saw this a little bit in respiratory. I didn't harp on it too much because it's a little bit more chemistry than most of you are comfortable with. But as a result of this hemoglobin buffering system, more carbon dioxide gets to the lungs, and we're able to carry it there. Remember, only 7% of your CO2 is dissolved in plasma, and then about 23% was on hemoglobin, and then the rest of it was converted through this bicarb story. So that here I'm talking about that part that's on the hemoglobin, that 23%. That's that buffering system. And so we saw that in passing again before. That CO2 that is coming in from your tissues is going into your red blood cells, and some of it's being carried on hemoglobin. About 23% of your CO2 is carried on hemoglobin. That's the buffering I'm talking about. It's kind of hiding that CO2, and then when the red blood cells travel back to your capillaries, they then convert that CO2 back to gas and allow it to be exhaled. Then finally, there's this carbonic acid bicarb buffering system. This is what is in your plasma. This is the one you've seen most often, that equation that you've seen with the carbonic acid, the bicarb, and the hydrogen. So this is that equation, and it was on the last slide as well. So CO2, right? We can take CO2 and water and make carbonic acid. I'm kind of going backwards on this. That carbonic acid can be broken down to H plus and HCO3 minus, bicarb. So if you add more H into your blood, it can bind up with this bicarb and get sort of taken out of commission, and eventually it does get to the lungs to be blown off. Now what happens when this goes wrong? That's what's really important here. So we've got these buffers, but what happens when there's a acid-base disorder? In other words, for some reason, your production of acids is overwhelming the system, or perhaps one of these systems is deficient. These disorders come in two basic flavors, respiratory and urinary. So first we'll talk about respiratory acid-base disorders. In other words, the primary problem here are the lungs. So when we're thinking about acid base in lungs, what comes to mind? CO2, right? So the lungs are not getting rid of the CO2. That means what's happening? You are accumulating CO2 and your blood is becoming more acidic. What would your kidneys do in result to that? The kidneys would try to compensate. And the kidneys would try to compensate and get rid of that acid. So what happens? Again, there's an imbalance in getting rid of or in the making of CO2. As a result, the respiratory system cannot work alone, and the imbalance will be, well, first of all, what will your lungs do? If you're making too much CO2, what will happen to your respiratory rate? You're going to try to blow that stuff off. So you're going to try to get more oxygen in. You're going to try to blow more CO2 out. So your respiration rate will go up, right? And your lungs can only do so much to make up for it. And then your kidneys will kick in as a secondary backup system. Now flip it around. What if the lungs are okay, but your kidneys are not keeping up with the metabolic acids? So now for some reason your metabolism is spewing out acids. Your kidney can't keep up. Now what's happening? There's extra acid. What might your lungs try to do? So at this point, your acids are increasing. We're going to call it the metabolic acidosis. And in order to restore homeostasis, yes, your respiratory system will try, right? It will increase your respiratory rate, but your kidneys will also try to kick in. Your kidneys are going to try to get rid of more H. How do your kidneys get rid of H plus? They do more secretion. So your kidneys would increase the secretion, trying to remove more of the acid, right? Try to get more of the acid. The other thing they'll do is they'll try to reabsorb more bicarb. Now I need you to think about that for a second. The kidneys are going to get rid of acid, but they're also going to reabsorb more bicarb. What does bicarb do? Bicarb, HCO3 minus, was what could combine with hydrogen, right, to take it out of the system. So you want to get rid of acid by squirting it out, but you also want to retain as much of the buffer as you can. So the kidneys are going to excrete hydrogen, but reabsorb more bicarb. And that's going to help restore the imbalance. And that's shown for you here on this image. If you increase the acid, yes, you have the carbonic acid bicarbonate buffer system. That's going to get acid over to your lungs. But your kidneys will also help by getting rid of that acid and replenishing bicarb. So this is a nice figure, 25.9. 25.9 kind of puts all of these systems into one image and gives you a more global view of it. And I'm not going to go into the steps of this. So I'm not going to worry about how the kidney does this. Just know that the kidney is going to try to get rid of more acid and reabsorb more bicarb. There can also be metabolic alkalosis. Okay. Typically, your body's not going to make too many bases. But this would be a situation where there's a large number of H's are removed from the body fluids, and that can raise the pH. And the kidneys, again, will try to compensate. So if you had too much, alkalosis means what? You've got too much base. So what's your body going to do to compensate for all that base? It's going to try to add more acid. So what process would the kidney slow down? The kidneys are going to slow down secretion, and then they're also going to try to get rid of bicarb. It's the other way around. So if your pH is going up, your kidneys are going to try to bring in more acid, right? Which means less secretion, and they're going to try to get rid of the bicarb, because the bicarb is part of that problem. So let's get rid of the bicarb.
So they're going to secrete less hydrogen and secrete more bicarb?
Yes, so they're going to retain more acid and get rid of more bicarb. So that's metabolic alkalosis. What would your body do? What would your breathing do? Increase or decrease? Decrease, right? So your respiration rate would actually go down, because what do you want to do? You want to hold on to that CO2. You want to hold on to that acid. You're becoming basic. So your body wants to hold on to acid. So let's not breathe too fast. We want to hold on to that CO2. Okay. It does make sense, folks. Okay. What your body's going to do in response to a high or low pH. And again, here's 25.9, and it's the same thing, except now it's the other story. We're not adding hydrogen. Here in this story, we're removing hydrogen. Therefore, our pH is going up, isn't it? Okay, if our pH is going up, this is what's going to happen. It's just a complete reversal of the other image. Again, I'm not going to worry about how the kidney does this. So we'll cross off that slide. So what we're talking about here is the marriage of the respiratory system and the kidneys, and what happens when one or the other is deficient, and how the other system will try to pick up the difference. So if the kidneys are not doing well, the lungs will try to pick up the difference. If the lungs are having trouble, then the kidneys will try to pick up the difference. Respiratory acidosis. This means that you're becoming acidic because of a problem with the respiratory system. That means that your rate of CO2 being made is exceeding the amount of CO2 that you're removing. How are you going to fix it? Breathe faster, right? So the body, the lungs will do that. So again, this guy, right, you've got not enough CO2 going out. That CO2 is going to come into the body, and as a result, your body is going to take care of it both with the respiratory and the urinary systems. And respiratory acidosis, we've already been here. This is like emphysema, right? As a result of this, you're accumulating acid. Your lungs aren't able to function properly. You're going to increase your respiratory rate, and your kidneys are going to come to the rescue to help get rid of more acid. So these are nice little slides. They're nice little slides. Now, what if you have instead respiratory alkalosis? Again, that means what? The lungs are at fault for what? Breathing too fast. You're getting rid of CO2 too fast. You're getting rid of acid too fast. So what are you doing? You are hyperventilating, right? What do we do for these patients? What do you do if your friend is hyperventilating? paper bag, right? Why?
To re-inhale.
You are blowing off too much CO2, right? As a result, your pH is going up. We want to recapture that CO2, so put a brown bag on them, right? And let them recapture the same CO2. So you're now giving them acid back, basically, by allowing them to breathe back in their CO2. So if you're hyperventilating, your blood pH is going to go up, brown paper bag, and you're going to recapture some of that. And that's what this is referring to, okay? So that what I want you to think about is what are your lungs going to do and what are your kidneys going to do in response to an alkalotic or a acidotic response. I'm 2 minutes over on a 14-week semester, and I apologize. 12 weeks. 12 weeks. I was also 1 minute over yesterday on 105, so I'm got this down pretty good. Okay. Now, test, mostly urinary and acid base. This little bit's important. So look back at, again, kidneys and lungs, how they're going to respond. Tell a story. Don't try to memorize this stuff. Tell a story. It makes sense. It makes sense what the body's going to do in response to these situations. And then the reproductive, do look back and look at that. Remember, there's no lecture next Tuesday. So really, your next big thing is your lab exam. Go knock that out. Do well on that. And that's also urinary. So I would suggest that before you take the lab exam on Tuesday, that you do the urinary quiz online. Even though that urinary quiz is related to the lecture, I'd hate to see some little ideas come into focus that could help you out on the lab practical related to the urinary system. So I would suggest that your goal before you take the lab exam is to finish the PAL quiz for sure and finish the urinary quiz online. It's not due until Tuesday night, but I would suggest do it before that so that information is part of your studying for the lab exam, which is also urinary. And that would leave you the reproductive systems to focus on quickly. I know, I wouldn't wait on those too late, but you have your reproductive lecture and your quiz, and that's due Wednesday night. Okay. And make sure you've made your appointment with the testing center. Again, if for some reason you want to take the lecture exam on Wednesday, you must email me so I can let the testing center know when you show up that it's okay. Other than that, I hope you guys have a great weekend. Come see me if you have any concerns on your grades. Anybody who's listening, Friday night at midnight is the last time to drop, so email me immediately if you have concerns about your grades.